So when people ask me about the work, I kind of explain to them that it's actually everything we're doing as a healthcare organization. It touches every aspect of what we do, even if you're not directly facing patients. And so it's made me rethink a lot of our processes and practices and protocols, the way we communicate. So it's made us revamp, how do we interact with our staff members? How do we hire staff? How do we train staff? How do we communicate with our patients? How do we do patient education and provide necessary guidance?
Welcome to the Health Pilots podcast, presented by the Center for Care Innovations. This podcast is about strengthening the health and well-being of historically underinvested communities. Every episode offers new ideas and practical advice that you can apply today. What does it mean to be trauma and resilience informed, and how does it impact pediatric care delivery? To answer this and to share with us deeper insights into the work, Health Pilots is featuring dedicated care teams from the Resilient Beginnings Network at the Center for Care Innovations. Facilitating this conversation with the team we have today is Dr. Dana Long, primary care pediatrician and clinical director for the Resilient Beginnings Network, or RBN for short. Hear the team's journey through this program, the valuable lessons they've learned individually and as a care team, and the unique transformative impact of the Resilient Beginnings model on patient care. In this episode, you'll hear our guests speak about adverse childhood experiences, known as ACEs, as well as the screening tool to address ACEs called Pediatric ACEs and Related Life Events Screener, otherwise known as PEARLS. For more information about these concepts and tools, please visit our episode's show notes. With that said, I'll pass it on to Dr. Dana Long for our episode today.
Hi, I'm Dr. Dana Long, a pediatrician at UCSF Benioff Children's Hospital in Oakland and the medical director for the Center for Care Innovations Resilient Beginnings Network. I'm thrilled to be here today for this podcast that highlights the incredible work that the Lifelong Medical Center has been doing as part of the Resilient Beginnings Network. I'm here today with Jillian Finn and Dr. Omatoso from Lifelong Medical Center.
Hi, I'm Amadi Amatasha. I'm a primary care pediatrician and the Associate Medical Director of Pediatrics at Lifelong Medical Care. And so I practice my primary care pediatrics at the Lifelong William Jenkins Health Center in Richmond. And so we've kind of been on this journey now 5 years of trying to make our organization more trauma and resiliency informed.
Hi, I'm Jillian Finn. I'm a licensed clinical social worker. I'm actually retired from Lifelong now, but I worked there for 15 years, mostly as a mental health clinician in one of the clinics, and so worked with NIHI for probably about 4 years, NIHI, I think, around the effort to make Lifelong a trauma-informed organization.
You both started to touch on the history of Lifelong Medical Center. Can you tell us more about your clinic, the populations that you serve, and the work that you're doing there?
Yes, thank you. Yeah, Lifelong Medical Care has about 15 locations that provide integrated primary care, both throughout Alameda and Contra Costa County. And so we see the whole age spectrum from newborns through geriatrics. We also do prenatal care and integrated behavioral health. And so we're a federal qualified health center. And so majority of our patients are on medical or uninsured. And so we work with lots of underserved communities. And so we have a wide spectrum based on the clinic locations. We serve quite diverse communities.
Before you started this work and joined the Resilience Beginning Network, what did trauma and resilience-informed care mean to you?
So, Dana, because I'm a psychotherapist, this meant treatment and education for families to me. I had many years of working with trauma, especially with mothers and young children. So I was working with people who were already traumatized. It's sort of like, to try and set things right. So I was really interested in the Resilient Beginnings intent to build resilience through primary care. I thought that this was an amazing public health opportunity, that if we could do this, we could prevent some later chronic illnesses, since, adverse childhood experiences has educated us so well on the connections, right, between early trauma and later illness. So I could see that this was a great opportunity for perhaps prevention, but also early detection and developing resilience.
So it sounds like, Jillian, what you're saying is that as a mental health provider, you've always dealt with trauma. And prior to Resilient Beginnings, your framework was that you were thinking about trauma-informed care and resilience-informed care as a treatment. But now when you put on this public health lens, you're thinking much more about primary and secondary prevention long before the treatment needs to begin. Is that what I'm hearing from you?
Yeah, that's right. That's what I saw in what the Resilient Beginnings was aiming for. And I was very excited about that.
Exactly. Nee, you are a primary care physician who's been practicing for a while now. What did this shift mean to you as a provider?
It was huge because I was not familiar with the language, trauma and resilience informed before we applied for the first grant. As a primary care provider, I was used to working with families that have been traumatized and trying to figure out how to deal with the traumas they've experienced. And for me, one of the reasons I got into pediatrics was to focus on primary and secondary prevention. And so when this grant opportunity came along, I was excited because I was like, this talks about dealing with prevention, a focus on prevention rather than just treatment, which is a lot of what we do nowadays. And so I was very excited to figure out, how do we do this in a way that is impactful for the patient families we work with.
So how do you do it now? What has changed?
I would say everything, to be honest. Yeah, it's funny. When we started this, once I learned the language and realized what it entails, I realized quickly that it actually impacts the way we practice medicine. Literally everything, So when people ask me about the work, I kind of explain to them that it's actually everything we're doing as a healthcare organization. It touches every aspect of what we do, even if you're not directly facing patients. And so it's made me rethink a lot of our processes and practices and protocols, the way we communicate. So it's made us revamp, how do we interact with our staff members? How do we hire staff? How do we train staff? How do we communicate with our patients? How do we do patient education and provide necessary guidance? So I think it's changed, and I realize now that really it is everything we do.
Yes, I agree with Nihi. When we first joined the Resilient Beginnings, I had imagined that our work would be pretty quickly about directly strengthening our work with young families, right? Without thinking through what that would entail. And we quickly found that we needed a much broader view than that. So, for example, we found that many of our staff needed a great deal of support before they were comfortable talking with families about trauma, if they were patient facing. And so it meant that we really had to look at the kind of systemic change that he's talking about, that everybody had to be involved in this, and that we had to work with staff before we really could ask them to work with families with children in a different way. So it's a journey. We learned a lot as we went. I mean, the goal obviously is ultimately still how we serve young families. And, Resilient Beginnings gave us several projects to do. And I was looking through the last project that I was involved in, and I really liked what Nee had said about what's our desired future. and how we imagined a family coming to a lifelong pediatric clinic would be served from the moment they walked in the door, right, through to how they were seated and how screening tools were explained, and even to a provider and an MA, for example, having even just 5 minutes after a visit to just check in with each other about how the visit went, and those may not seem huge, but they are when you're working in a large organization and you have many levels of staff to work with and tight schedules, always time. How much time do we have to do this work? So, and I've been really delighted with how it's progressed. It took time. And that was another thing we learned, I think, Nihi, right? You had to be really patient and hang in there to be able to do these things. Yeah.
A lot of patience. Yeah. I think, going into it, I still had a narrow mindset of, dealing with ACEs and how do we set up to screen.
Yeah.
And like Jillian said, when we started looking into dealing this with staff, realized that we actually needed to pivot and focus on the office environment, which was one of our aims in the first grant, was what can we do to better support our staff and the environment they work in, before we start talking about, changing the way we attend to patients or interact with our patients. And that was very eye-opening, actually, to learn that lesson.
And how difficult it was to do, if you remember. We had chosen our first spot that we thought needed trauma-informed care the most and found that we really had to back away, that our expectations were too high, that there was a lot of groundwork that needed to happen at that site before we could ask people to start doing things differently.
So walk me through that. I've heard both of you comment that staff needed support. We needed to change the environment. What is it that you changed and how did you change it?
Yeah, so the first thing we did was one of the sites we thought would need this the most, given the kind of level of traumatized patients they saw on a regular basis. And so we went into that site and talked to the leadership at that clinic and talked to them about the work we're trying to do and how it was impactful for the patient families. And we felt that was a huge need at that clinic. And so we were able to get buy-in to start having monthly meetings with the staff. And coincidentally at the time, we also had a county child psychiatrist that was also in the clinic consulting. And she agreed to collaborate with us to lead these monthly meetings with staff, where we started off just talking about stress and trauma and the impacts it has on the body and how it can appear, in different people. And when we see someone in clinic, that could be what's going on, as opposed to people just misbehaving. And how do we approach and deal with that and, keep that in mind as we approach patient care. And then talking about how that can impact, our social emotional state, but also especially kids. And so through a series of lectures, we would provide lunch and do these talks and discussions with the group. And after that, we tried to introduce ACEs, and we watched the TED Talk that Dr. Midian Bakharis had made. And, another session, we went through the ACE, the Pearl screen itself, explained how it works, went through the questions, had people anonymously look through it in the room and kind of give their feedback. And that's when we realized that a lot of people were very uncomfortable with the kind of questions we're asking. And partly because a lot of them had also experienced those traumas themselves that had not been addressed, And so it was kind of eye-opening to us that, we had gone in thinking everyone is motivated to do this work, but then realized that people had to be emotionally ready to do this kind of work. And how can we support them to do it? And so luckily, me and one of my colleagues went to a site visit through the Resilient Beginnings to Montefiore in New York and kind of saw how they changed the office environment and culture to do this work. And that's when the light went off that, we actually need to change how the culture is and the environment of the office and support staff before we start moving on to trying to address this with patients.
Mm-hmm.
And so we completely had to start from scratch on our approach to making organization more trauma-informed.
Right. We also recognized that maybe one of the most important things we needed to do was orientation. And we worked for a long time to get some acceptance that perhaps all new staff coming to Lifelong would need an intensive on trauma-informed care. Like, a 1 hour session is not enough. You really need something more than that, and for an opportunity for people to process it, to set the expectation that this is what Lifelong wants to see happen, that Lifelong wants to be a trauma-informed organization. And so how do you spread that through? How many clinics, Nihi?
We have 8 pediatric clinics.
8 peds clinics.
Across 2 counties, yeah.
And for the rest of them, there are also other primary care clinics that don't serve peds, about 15, I think, maybe?
Altogether, yeah.
How can you spread this message across that many clinics? And so doing a new staff orientation was something that we thought was an important step. And I'm happy to say I am not doing it because I have left the organization, but the momentum kept going forward. And now that in fact is happening. And I think that was a really good move too.
It sounds like now this work has become a priority with leadership as well. That sounds like it was a transition, right? And so making it a priority with leadership is something that we hope that clinics will do. Can you talk about how you helped that transition to happen?
We kept plugging away, raising it in every forum that we could. I think a little bit of progress happened when we had to do the presentation on selling your program, right? And so somebody from the C-suite did come to that. And that had always been our hope, that the C-suite would pick it up. From my point of view, it also helped that behavioral health finally had somebody in the C-suite. And so the behavioral health team was also working on this. And, behavioral health is integrated in the clinics, but still they do their own work. And so they had been implementing, for example, they had a state grant for screening for trauma during the perinatal period. But so that the leader of the behavioral health people had a great understanding of this. And so, Nihi, what do you think? Do you think people finally started talking to each other? Was there a pivotal moment? What do you think?
I think it's been a slow grind over the years, I would say. Yeah, because, what we tried to do was, like Jillian said, reach out in all kinds of forums. So we had monthly medical director meetings. And so it was a topic we brought up as a way to deal with issues we were having in our clinics when it came to staffing and staff morale and turnover. We brought it up with the senior leadership team, as Jillian said. Shortly after the initial work started with the Resilient Beginnings, we had a strategic planning for organization for the next 5-10 years. And so we honed in on those pieces of it that focused and aligned well with the trauma-informed care work we're trying to do, especially around staff engagement and wellness. And so we talked to our leadership team, about how this could be a good way to achieve those goals. And when we finished the first grant, we had the presentation we did to our senior leadership team about the work we're doing, how it relates to our strategic plan, and kind of the things we could do as an organization to help move that forward and opportunities for it, and gave recommendations and lists. And so over the next couple of years, we've been meeting regularly with our leadership team to discuss ways in which our work aligns with what we're doing. For example, a couple of years ago, they restarted a diversity, equity, inclusion, anti-racism committee and started doing some work. And we also got involved with that as a way of how this is all trauma and resiliency informed. And so we've basically tried to put ourselves in the room with all these discussions, seeing that it really all relates to the work we're doing in some way.
Yeah. I'm just thinking, I think when Maggie Edmonds joined the team, that made a difference too, because what is Maggie's role in the organization? Is she deputy CMO?
Yeah, Dr. Edmonds. Yeah.
That's right, Dr. Edmonds. Yes. I think that also gave us a little bit more of a voice, right? A passageway, one more voice added that could speak to this and knew what we were doing, and also could give us feedback about what the possibilities were and the ways to approach things sometimes. I think that helped as well. And then also, once you managed to get a project manager, right, who could liaise and also make goals actionable, I think that made a big difference.
I'm wondering, I think that this is really important to think about like how senior leadership has evolved. I do want us to think about community and patients though, like as well. Mm-hmm. How do you think this work has actually trickled down, and how is it influencing the way that patients are experiencing lifelong?
Yeah, I think it's a little difficult to say because we haven't had a formal process of getting feedback from patients. And so I think from my personal experience as a provider, part of the changes we made as a result was trying to be more engaged with our community and our patients. And so, for example, when the pandemic started a few years ago, and there were lots of increased social mental health needs in our community that we serve, it prompted us to start screening for that as part of a pilot and trying to figure out how to help families address those needs and link them to resources. And so in that process, we kind of learned to practice engaging families and asking what kind of resources or helps do they need and in what ways would they like to receive it. And so we've started actively using that to influence any changes we make in the way we practice in clinic, to make sure we're getting feedback from our patients as we do that, so that we can make changes along the way that best address what their needs are in the way they want to implement. So I haven't gotten direct response from it, but it's definitely changed kind of how we view programs we run, from being kind of, just intentionally to more, how is this engaging our patients in the way they want to be engaged?
And one of the things that we identified was, and I'm not sure that post-pandemic really that work has happened yet, but we agreed that we needed a patient voice collaborative that reflected younger families, right? That Lifelong has always had those collaboratives, but that they probably needed to be separate collaboratives that gave us a patient voice to younger families. There are challenges with that, of course, but I'm sure that would still be something that would develop.
I love hearing about the patient voice collaborative. Really important to center family leads and patient experience so that we can co-make decisions. Can you tell me a little bit more about that collaborative?
Well, the collaborative, when I was there anyway, the collaboratives that existed were mostly comprised mature adults, right? And the idea was that they had an opportunity to come together and give lifelong feedback about how they felt about their care, any ways that they thought that the organization could serve them better, right? So that was a group of patients that would come together and meet with the staff person and talk about their experience. And then, of course, in addition, Lifelong always regularly did patient care surveys with patients. But the feeling was that young families have different needs from mature adults, right? And so that would be something that would be good to develop. But, what I will say is that there are many things that I know that the team still wants to achieve. COVID, of course, made everything so much more complicated, right? And one of the things that I'm aware of is that so much of the care is being done from people's homes now, that sort of the opportunities for collaboration and integration are probably a little less than they were. So I'm sad to hear that we're now coming into probably another serious COVID season. And I hope that it doesn't, undermine all the great efforts that the team is making now.
As you both know, Resilient Beginnings Network is a collaborative of 15 different clinic sites or health systems. What were some of the best practices that you picked up from other learners that have influenced how trauma-informed and resilience-informed care has rolled out in your clinic?
Yeah, I'll still go back to the Montefiore experience because that really changed or transformed my whole approach and mindset to this work. Because I could see how they kind of intentionally made this a cultural shift and got everyone involved in it to understand and educate on the culture and what it meant and embody it in their work. I think the highlight for me was at the site visit when the chief security officer presented to us and talked about how it has helped him and give examples of relate to staff, where he has staff that are hired, how he notices when patients walk in that, okay, this person usually comes in, but today seems like something is going on, and how they communicated that to the staff in the clinic seeing the patient. And also how even his own staff, when they have things going on in their lives, is able to support them and told them when to take a break or maybe you shouldn't come in today. And it kind of blew my mind that this is really what we're talking about, that everyone is understanding what's going on, but also embodies what we're trying to do. I was really blown away, to say the least.
And what I remember is, I can't remember which organization it was, but one of them where the CMO and CEO had been really enthusiastic about the whole approach. And they were able to describe exactly what they had done within their organization because of that support. And so that, for me, was just a reminder, keep going. We have to get the C-suite involved in this, our leaders. It will make a huge difference to the organization if our leaders at the top get involved, because then you have much more chance of creating new norms, right, and policies, which are hard to do from the bottom up. So I remember that, and I kept reminding myself of that when it got hard to try and get leadership buy-in. The other thing I remember was when we first started thinking, well, how on earth would we do the screenings, that it was helpful to hear, I think it was Ravenswood, and one of the other clinics who just explained in detail who had the screening tool, how they had trained their staff to offer it, who looked at it when, what was the follow-up to what, if there was a score on the adverse childhood experiences screening tool. So that was reassuring to hear a clinic had actually managed to do that and how they were carrying it out, because it had felt a little impossible at the stage that we were at. I will say that it was really helpful to be part of that collaborative just for the support, even though we often felt that our gains were meager compared to some of the organizations at times, but that didn't matter. It was really helpful to just hear what everybody was doing and know that we were all doing the same work. It's really important for any new venture to have support like that.
I'm hoping that you can share with us about an experience or a situation that illustrates the amazing work that you're doing.
One example that kind of sticks to my mind is one afternoon we were in clinic and I could hear a kid and the mom screaming as they were being roomed. And I wasn't sure what was going on because from my schedule, I don't remember any particular family coming in that afternoon. And so I was actually in another exam room seeing a patient that it was so disturbing. I actually had to pause and excuse myself to step out to figure out what was going on. And so I stepped into the triage area and saw this kid that was crying and screaming, and the mom was also shouting. And I walked in to talk to her because I knew the mom, to figure out what was going on. And mom was shouting into a speakerphone to someone because her kid didn't want to get his blood checked with a finger prick. And she was shouting to someone on the phone that she can't just handle this. And I went in to talk to her to ask what's going on or what happened, and mom at that point was like, we can't do this. Let's go. And then got her son and left the clinic. And so at that point, I kind of had to go back to finish up with my other patient that was there. And then after that, I went to talk to my medical assistant and we kind of checked in together, like what happened, because that never happened to that family. They were always very polite and this was very unusual. And so we kind of talked and I was wondering what happened. And so we called the family later and talked to mom the next day that, yesterday didn't go well. Hope everything is okay. And mom agreed to bring the kid back a week later for a checkup. And so at the next visit, the kid came with dad in for the visit. Mom waited outside in the waiting room. I didn't know at the time. And the kid came in, we talked to the kid, what we're going to do, got his finger pricked, everything went fine. And then mom came in and joined us in the room and apologized for what was going on. And seems like she had been stressed at that time when this happened. She had just found out she was pregnant and there was a lot of stuff going on. And she apologized. We sat down, had a good talk and chat. We're all laughing when they left. And then I talked to the medical assistant afterwards, and she kind of understood and kind of took us back to the trauma-informed care training we did at the beginning about, instead of what's wrong with you, what happened to you. And that just kind of symbolized, and showed me how this work is really making a difference in how our staff interact with patients, even in difficult, stressful situations.
One of our faculty members from Vital Village talking about, this is Dr. Renee Boynton-Jarrett, talking about the dignity framework really stresses these three elements of dignity, which are to respect dignity, to defend dignity, and to restore dignity. And that example that you just said, it is such a beautiful example of restoring dignity and the healing that comes from that. And so thank you for sharing.
That's lovely. I really like that. So what came to mind for me, Dana, was remembering a centering parenting group that I was co-facilitating. And we had decided that we were going to start introducing the concept of, ACEs, adverse childhood experiences, and the screening tool, but we would do it in stages, right? So one session just explaining the concept, and another explaining the connection of chronic illness to trauma. And then for this third session, by then, we were a really good cohesive group, I think with a fair amount of trust. And I asked the question, I said, how would you handle being asked to complete this screening tool? Would you feel comfortable being honest about some of these questions? Because I think that this is really important. We're asking people really important questions. And, initially, the group said, probably not. So I said, and why would that be? Because I would be afraid you'd be reporting me to CPS, which is a big issue, right, that came up for all of us in discussions about, screening for ACEs. And then I asked the question, I said, and if you thought about the fact that there are connections between a child experiencing trauma and the possibility that later in life they might have illnesses, does that make a difference? And they said, and the one mom said, oh, you mean like my child could end up with diabetes or heart problems? I was saying, well, unfortunately, the research does show us that a percentage of children who experience trauma might end up with those problems. And she said, oh, in that case, yes, for my child, I would share. And in fact, that mother asked for mental health services. And so that to me was significant. And I felt really informs the need to be honest with parents in a way that they can hear, not judgmental, but helping them to understand the science behind screenings for ACEs.
I agree with you. Offering the science and explaining the link between trauma and health outcomes is the way that I always approach ACEs screening with families, because families want the best for their children without a doubt.
Yes, they do. Yeah.
What are the lessons learned that you would recommend to other health systems and clinics who are just beginning this journey?
I think a couple. One I was thinking about was the idea of thinking big in terms of having a vision of what you want to do, but taking small steps to begin with. Because I guess sometimes we get carried away looking at the big picture and what we want to visualize, and we forget that really we should start with little building blocks, and using each opportunity to celebrate your successes and what you've learned and see it as learning opportunities as opposed to failures in itself. Because it's a long journey, that places we've been to that have done this well have been doing it for decades to get to where they are. And so it's nice to keep that in perspective as you begin your journey, that this is a process that takes time.
Yeah. Yes, I totally agree with Nihi. I had written down, hang in there, just keep going. And when Nihi's saying celebrate your successes, that was something as a team that we began to do. We recognized that we really needed to do that. If we were not feeling like we were making big steps forward, we want each of us would share anything that had happened in our corner of the organization that you could say was part of a trauma-informed approach or working towards it. So small successes, I think, kept us going whilst we were trying to get the big successes. And the other thing I would say is you have to have some dedicated staff time in order to put action to your goals. That was one of our greatest challenges, was it took a long time before we really had dedicated staff time that could follow through and make the smaller goals happen, tasks. Somebody needs to set it in motion, monitor it, pulling the people who will achieve this, persuade, make sure that there are timelines, all of that kind of thing. So staff time is really important to a project like this.
What is next for you at Lifelong?
I think the few opportunities we're kind of using. One was we were able to leverage the experience from the Resilient Beginnings to start piloting AC screening at one of our clinics using another grant. And I think without the experience from Resilient Beginnings, we wouldn't have been prepared to take that step. And so we're able to use all those experiences to help us intentionally start this on a good footing. So I think that was a big thing, and we're hoping to continue that. Another thing is trying to figure out how to do trauma and resilient informed care in a lot of things that we can do at the organization level. And so personally at our clinic, we've actually started doing centering parenting with pediatricians, as another way to kind of embody the trauma and resiliency informed care in early childhood. I think that's another piece. And then the big piece about changing the culture, like Jillian mentioned, is the new higher orientation. We're kind of working now to see how we can revamp it and also eventually take it to the clinics, to this clinic leadership, and eventually all staff to become part of their onboarding or regular training as well.
I thank you both for sharing your experience and your wisdom with us. Thanks to Jillian Finn and Dr. Omatoso.
Thanks, Dana.
Thanks for having us.
Thank you for embarking on this episode of Health Pilots, hosted by the Center for Care Innovations with podcast production services by Wayfair Recording Company. Special thanks to Dr. Dana Long, the Resilient Beginnings team at CCI, Trauma Transformed, and the featured pediatric care team that has joined us today. Check out this episode's show notes for relevant links, resources, and opportunities. And if you like what you heard, please spread the word. We're available on all major platforms, and be sure to subscribe where you listen to podcasts. For more information about the Center for Care Innovations, or for upcoming programming, events, and funding opportunities, please visit our website, careinnovations.org, and connect with us on our socials, LinkedIn, Facebook, and Twitter. This is Wes Cabrillo at the Center for Care Innovations, and we appreciate you tuning in. Catch you on the next episode of Health Pilots.